Welcome to the Adult Obesity Guidelines webinar series hosted by the Office of Lifelong Learning and Obesity Canada. My name is Denise Campbell-Scherer. I am the Associate Dean for the Office of Lifelong Learning and the Physician Learning Program, as well as a family physician here at the University of Alberta. It was my great pleasure to serve on the executive of the Canadian Clinical Practice Guidelines for adult obesity. The new 2020 Clinical Practice Guidelines are expansive, 19 chapters on a wide range of topics related to obesity diagnosis and management, weight bias, and more, all written by Canada's top researchers, health practitioners, and patient advisors. They're the first truly patient-centered clinical practice guidelines on obesity and the result of more than 3 years of hard work. Just before we begin, I'd like to go over a few items. We acknowledge that we're on the traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. Please contribute your experience with obesity management to our advocacy and programming. So if you're waiting or after the event, please take 5 minutes to contribute your perspective by scanning this QR code. We are very pleased to have Dr. Mary Forhan, Pam Hung, and Cindy Grant to present Enabling Participation in Activities of Daily Living for People Living with Obesity. Dr. Forhan is an occupational therapist, associate professor, and chair of the Department of Occupational Therapy, Faculty of Rehabilitation Medicine at the University of Alberta. She was recently appointed Scientific Director-elect for Obesity Canada and will start a 2-year term effective April 2021. Dr. Forhan leads the Bariatric Care and Rehabilitation Research Group that aims to reduce the disability experienced by persons living with obesity by addressing factors that restrict participation in the activities of everyday living, including access to places and spaces where people live, work, play, and seek healthcare services. Pam Hung is an occupational therapist with over 10 years experience working with patients and health professionals in the area of obesity. She was the first occupational therapist to work in the Edmonton Adult Bariatric Specialty Clinic and was part of the multidisciplinary Provincial Bariatric Resource Team, providing clinical leadership, education, and resources to improve healthcare for people living with obesity. She has supported education for occupational therapy and health science students across the University of Alberta. Pam recently started her PhD in rehabilitation science at the University of Alberta and is passionate about developing further research and education in obesity and rehabilitation. Cindy Grant is a physiotherapist with 17 years of clinical experience. She worked on the multidisciplinary Provincial Bariatric Resource Team for 5 years, supporting clinicians working with the patients with bariatric care needs across Alberta. After completing a Master's of Public Health, she began supporting large-scale health system change initiatives and is currently working in organizational change management. Cindy has a passion for supporting the care and health of Albertans and the work of the healthcare providers in our ever-changing and complex health system and in the ever-changing and complex world we live in. So welcome and thank you so much.
Thank you, Denise, and thank you everybody for joining us today. It's my pleasure to introduce the chapter on enabling participation in activities of daily living for people living with obesity. This was a unique opportunity for my occupational therapy and physical therapy colleagues to be able to contribute to this guideline, where we are going to talk a little bit about just how people manage day to day in their everyday activities and some key questions and recommendations that practitioners can make sure that they check in with their clients. So here we go. So key messages that we're going to highlight in this chapter are really about asking patients about their performance of daily activities. And this includes things like personal care, which is bathing, dressing, getting in and out of bed, moving about their home, how they get in and out of chairs, in and out of a bathtub, in and out of the shower, these kinds of everyday activities that everyone participates in and often aren't asked about when they're meeting with their primary care physician or any other healthcare professional, unless it's an OT or a physical therapist, a PT. These questions usually don't come up. We also want to ask our patients about their interactions with the built environment. How is it that they move about the spaces and places that they perform their activities of daily living? So this includes their home environment, their work environment, their leisure environment, their social environment. The other things we want to ask about is how they're feeling. What is the sense of safety and sense of belonging when they're interacting with their social environment? Are there barriers that are preventing them from feeling fully engaged and being able to participate in the activities that are both meaningful for them and things that they also need to do to go about their day-to-day routine? This information is really valuable, and it really provides a nice database of facilitators and enablers that help people engage fully in the activities that, as I said, are meaningful. And it will allow you to start to identify targeted treatment interventions that might help identify adaptations to the built environment or the social environment, or different ways of approaching a daily task that makes it safer and more accessible for some individuals who are living with obesity. So, the places and spaces where healthcare service delivery takes place needs to be physically accessible. It needs to be equipped with the right equipment and supplies that allow you to do the work that you need to do with your patient, but also for the patient to feel safe and respected during that therapeutic intervention. So, when patients come in to a primary care setting, for example, they need to be able to access the full range of those services. So that starts from the moment they need to come into the building where your practice is. Is it accessible? Is there an elevator? Is the elevator going to be large enough to be able to accommodate any mobility equipment that the person may use? Or maybe they're coming with someone who provides some personal care support. Can both people fit in there? Is there room in the waiting room area where a person can sit comfortably and feel safe and included in that environment as well? We also want to make sure that you think about that journey throughout the assessment process, any meeting rooms that you may interact with a patient, including your own office if you do consultations in your office. Is the exam table accessible? Is the washroom facility in your care area accessible? And is it safe and provides a respectful environment for every aspect or touch point, as we like to refer throughout that journey in your primary care setting? So you want to think about the accessible features and even things like public transit. How are your patients getting to and from your office? Another key message we have in this chapter is about injury prevention. And this includes falls risk reduction. This is really important and something that we've heard from many clients that they're not asked about. So sometimes recommendations will be that, try to get out and about, move more, walk more. But if a person is fearful of falling, they're not likely going to readily state that, or they might not even be aware that that's a barrier for becoming more physically active. So it's really important that you ask about fear of falling, how they're feeling stability wise as they move about their spaces and places, and also thinking about a falls risk assessment. So there are some psychometrically sound assessments that are available out there. They don't take a long time to do, and it allows you to start to identify if there are some maybe physical restrictions, postural control, lack of balance, maybe some lower extremity strength that might be interfering with a person's ability to feel safe and to be able to move about without falling. So that's really important to check that out with your patients. Another key message is that patients report significant challenges with participation in their activities of daily living might benefit from a referral to an occupational therapist or a physical therapist. Often, many communities will have these available either through private practices, home care, community health centers, local hospitals or rehabilitation centers. So oftentimes this doesn't come up in primary care when you're working with clients with obesity, but an occupational therapist or a physical therapist can provide some much needed interventions and work with that client to expand on the work that's being done in the primary care setting. In some areas too, some primary care centers will have an occupational therapist or a physical therapist, or ideally both, as part of the healthcare team. So be sure to utilize those resources that you have available to you, and that your clients may also have some extended healthcare benefits to cover as well. Healthcare providers should also really look at the integrity of the patient's skin and the condition of any wounds. So skin care is really, really important and challenging sometimes in patients who may have larger bodies or skin folds. It's really difficult to self-monitor some of these areas in the body that are hard to see or hard to reach. So a nice assessment of the integrity of the skin is really important. So some recommendations that we have, I've mentioned some as I've talked so far, but we really recommend that healthcare providers ask patients if they have any concerns or have any challenges managing their self-care activities. And as I said earlier, things like bathing or getting dressed, bowel or bladder management. So often patients are uncomfortable raising these issues, may feel that they're the only ones experiencing these challenges. So it's really important to be really respectful, but ask about these possible challenges to give the patient an opportunity to disclose and to talk about them. And these are really important for people to feel that they can get out and about and do their daily activities, such as going to work, caring for others, social interactions. You also want to talk about how they're managing their skin and wound care, particularly with foot care, as that can be a very difficult area of the body to reach. We also recommend that healthcare providers, as I said earlier, assess those falls risks. Ask people about their ability to move about. And again, if a patient is identifying a fear of falling or feeling unstable on their feet, whether it's a real experience or something that they fear, it's worth investigating further and then making a referral to an appropriate service that might help that client, feel less vulnerable as they're moving about. So some key messages for people living with obesity. So every chapter in the guidelines has these sections, and ours is no different. So the restricted range of motion, balance, and mobility that some individuals living with obesity experience may impact their ability to complete self-care activities such as bathing, as I said, getting dressed, bowel or bladder management, and skin and wound care, or maybe even managing foot issues. So issues in this area may require some adaptation. So as an occupational therapist, what I'll often work on with clients is finding alternate ways of achieving or performing a task. So it might be that we provide some aids for daily living or assistive devices. And that could be a long-handled reacher. It could be a long-handled sponge. We might suggest alternate ways of drying off after having a bath, safe transfers in and out of the shower or the bathtub, things that help patients conserve their energy, reduce the risk and strain associated with some of these activities, and help patients be able to be as independent as possible in managing their self-care or showing their care provider how things might be done more ergonomically or with less stress and challenges. So some individuals living with obesity experience issues with mobility. And as I said earlier, they may be more at risk for slips, trips, or falls. And this could be through reduced visual field of not being able to see where the foot is placed on a surface, particularly with walking up and down stairs. We've heard from many patients that this can be quite a challenge. And oftentimes it's because the field of vision to see where the next step is, or if there's a change in the grade of the surface they're walking on, may make that challenging or higher risk. It can also be some patients living with obesity may have a panniculus or excess abdominal skin and tissue that is mobile, that moves about. And when moving about, if that's not secure, it can create momentum that can throw a person off balance. So these are all things that are important to pay attention to. So we really encourage patients living with obesity to share their concerns about mobility with their healthcare provider, because there might be some really easy fixes to how to manage that, or might require some more intensive rehabilitation interventions or strength training to help improve that. But if the healthcare provider doesn't know you're struggling with this, they're not going to likely think about asking about it. Another key message is that obesity is associated with an increased risk of skin issues. And this can result in redness, blisters, rashes, open wounds that can become resistant to healing and can actually become a high infection rate. So individuals with obesity, we encourage you to continually, routinely monitor the integrity of your skin or any wounds, and be sure to let your healthcare provider know of any changes or anything that's causing you pain or irritation. So these can be pressure points, and pressure points can happen from sitting, from leaning on surfaces, from things rubbing skin or causing some friction. It can cause skin breakdown, and there could be some infection risk as well. So really pay attention to areas in skin folds. And some of the things we recommend is to use mirrors. So use mirrors on long handles. We've had patients talk about using selfie sticks and having mirrors on the end of them so they can check areas of their body that are difficult to see. And if you have somebody that can help you check those places and spaces would be really important, just to make sure that if there is an issue that it's caught early before too much damage can be done. So your healthcare practitioner's office and clinical spaces really need to be physically accessible and equipped so that all patients, including individuals living with obesity, can really access the full range of primary care services. And that includes, as I said earlier, the assessment and treatment phases of any care interaction. So let your healthcare practitioner know if there are barriers that prevent you from fully participating and accessing the care that they have to offer. This really includes if you've noticed any issues about getting to the building, access to parking spaces that you can easily get in and out of your car with, public transit stops nearby if you take public transit, elevators, stairs, the seating, the access to the doorways, washroom accessibility. Oftentimes, individuals living with obesity don't think about the environment in which their patients need to interact. And so if you're noticing some things, it's really helpful to raise those issues with your healthcare team, because again, they may not have thought about it, and there's some really easy ways to make those areas accessible. And it's really important that you let people know that that may be a reason that prevents you from coming for follow-up visits or to take care of your own health if you're not comfortable or physically can't access the space. So I'm going to pass this over now to Pam Hung, and Pam's going to start to talk a little bit more about some very specific things that you can do to help set up your primary care practice.
Hello, everyone. Sydney and I will be sharing some practical tools that are included as part of the guideline chapter. You'll notice that these tools align well with the key messages and recommendations that Mary was talking about earlier. The first tool that I'm going to talk about is the Assessment of Clinical Space Checklist. This checklist provides some considerations for making clinical spaces more accessible to people living with obesity. Something that can be important to keep in mind about clinic space accessibility is that often if a space is made more accessible to people living with obesity, that space becomes more safer and accessible to everyone. One way you might consider using this checklist is to print it off and start from where people enter your clinic space, or even the front entrance from the outside. As you move through the space, you can use the checklist to consider areas that could be made more accessible. So starting at the top with the waiting areas, it's really important to be mindful of the reading materials and visuals in your clinic environment to ensure they are non-stigmatizing for people with obesity. Now, I realize you might not have a lot of reading material in your waiting area or other clinic spaces right now, but even just thinking about the visuals on the wall that you have throughout your clinic space. In terms of seating, there are a lot of different seating options that are available at a higher weight capacity, but it's important to keep in mind the dimensions, because there are some seating options that are available at a higher weight capacity, but the actual physical size of the chair might be the same as a standard chair, which may not be as comfortable for people. It's important to keep in mind that a really firm cushion and having armrests on chairs can make it easier for people to stand up from them. This is a good example of how the space can be a bit more made more accessible for everyone, such that if you have wider chairs available, other people might be able to use them, such as a caregiver and maybe a small child, so that they can sit together. It's important to integrate the seating into your existing seating so that there isn't necessarily a specific perceived area for a certain group of people, but having it integrated can be more inclusive. In the washroom, it's important that there's enough space around the toilet so that people can move around the space and be able to use different positions if needed. Floor-mounted toilets have a higher weight capacity than wall-mounted toilets, and so that might be a little bit more safer for someone. If there are specimen containers used in your clinic space, they are available with handles, which can be a lot easier for people to use if they have difficulty reaching. In the examination areas, there's a lot of different weigh scales available at higher weight capacities. Something else to keep in mind is to have something that has a wider standing surface that can be easier for people to maintain their balance. Having grab bars or handlebars on the scale can be helpful for people to get on and off. Also, having a chair and maybe a long-handled shoehorn nearby can be really helpful if people are taking their shoes on and off when they're being weighed. And having the weigh scale in a private area is really helpful. Exam tables, it's also important to keep in mind the size of that exam table in addition to the weight capacity, so that there's enough room for someone to lie comfortably and get on and off safely. With step stools, these are available with a wider surface area, and some of them have handlebars that can make it easier to use for people. In terms of other clinic equipment, there's a lot of different sizes available from a lot of different manufacturers of things like gowns and blood pressure cuffs and tape measures and other equipment that may not even necessarily be on this list. But it's important to keep in mind that the equipment that you're using for clinical assessment is that it's readily available. It's important to keep in mind that, you know, you don't necessarily want to have to say to someone, oh, I have to go get the larger blood pressure cuff. We don't keep it in this room. And then having that person have to wait. Having these pieces of equipment readily available helps to convey that message of inclusivity to our patients. So this isn't necessarily an exhaustive list, but it gives you something to start with in looking at your clinical space. The next tool I'm going to talk about is when to refer to an occupational therapist. Occupational therapists work with people to enable engagement in meaningful occupations. So for occupational therapists, occupation goes beyond just an individual's work role. Occupations are all the activities an individual does throughout their day. This might include self-care activities such as basic activities of daily living like bathing and getting dressed, productivity roles including school, work, and volunteer, and leisure activities. So there's lots of different areas where occupational therapists can support people living with obesity. This tool provides some categories where occupational therapists might address with people living with obesity, along with some interventions that might be offered by an occupational therapist. This is not necessarily an exhaustive list. It doesn't have every single role occupational therapists can play for people, but might give you some ideas and suggestions on where occupational therapy can help. So for people that have obesity-related comorbidities, occupational therapists can support people in educating clients on self-management of these associated conditions, just as we might do with any other client. Occupational therapists can also address mental health concerns by applying psychosocial interventions to address emotions, thoughts, and behaviors that could be impacting their health, supporting positive body image, as well as facilitating social engagement and participating in leisure. Another interesting role of an occupational therapist is to support clients in optimizing their time use. Part of weight management or obesity treatment might be integrating new activities or occupations into someone's routine, and sometimes that takes a bit of strategizing to help people work that in. With energy management, occupational therapists might work with people in two different ways. This might be on finding ways to increase energy expenditure throughout the day to increase the amount of physical activity that they're doing, but also how to manage limited energy. So for someone who might have chronic pain, the occupational therapist might work with them on finding different ways to save energy in some tasks, maybe some of those self-care tasks like dressing and bathing, through using some assistive devices so that they have a bit more energy and ability to manage other activities like going for a walk or maybe going to an exercise class if that's something that they do for physical activity. A significant part of the occupational role is education and skill building. And related to weight and obesity management, this might include things like meal planning, food preparation, physical activity, looking at other occupations and how people can be supported in being independent to improve their function. In terms of self-care, skincare management is a really important part of addressing any concerns that people with obesity management might have. This might be through education on the use of assistive devices or strategies on keeping skin clean and dry in order to prevent any infections. Other areas occupational therapists might support are stress management and time management as well, and really anything related to how people engage in their everyday occupations. Some other roles that occupational therapists might play are assessing and addressing home and community accessibility barriers, adapting the task or environment to facilitate occupational engagement. So an example of this might be doing a home assessment and looking at how someone's kitchen might be organized, and maybe they have trouble accessing the cupboards where their pots and pans are typically kept, and suggesting some ways they might rearrange their environment to make it easier to prepare their meals. Occupational therapists also assess for and recommend assistive devices. So this might include something like dressing aids, a reacher for putting on a pair of pants, or a sock aid to make it easier to reach your foot, mobility aids, and also abdominal supports if that's needed. Occupational therapists can also provide some education and recommend appropriate footwear as well. In terms of consultation and advocacy, occupational therapists work with the rest of the health team to coordinate referrals to other health professionals that might be appropriate to address some of the client's concerns, but also advocate for and support applications for funding for the purchase of assistive devices, if that's an option in your area, as well as advocating for participation in community programs and access to community resources. So like Mary mentioned earlier, occupational therapists can support lots of different ways for people living with obesity to engage in their daily occupations. And they can typically be accessed at community health centers, home care. It might be through private practice. It just depends on the way the system is organized in your area. So now I'm going to pass this over to Cindy, who's going to talk more about when to refer to a physical therapist.
Thanks, Pam. So I'm going to be presenting another really practical tool similar to the one that Pam just presented on when to refer to an occupational therapist. This tool is to help to identify when referral to a physiotherapist might be beneficial to your patients living with obesity. And physiotherapists are primary healthcare professionals that combine an in-depth knowledge of the body and how it works with specialized hands-on skills to assess, diagnose, and treat, but also to promote the health of individuals and populations. You might notice some similarities in the two tools, as occupational and physical therapists are both rehabilitation professionals, and so there is some overlap in practice. The tool is set up just the same. So on the left, you see some areas that may be a challenge for some people who live with obesity or for others in your practice as well. And then on the right, you'll see some types of interventions that might be provided by a physiotherapist. And similar to what Pam said, this is not an exhaustive list, but it's just to give you an idea of what you might expect from a referral to a physiotherapist. So the first challenge category is quite a broad one, challenges with movement, pain, or daily function. And it's really important to acknowledge that weight may play a role in musculoskeletal concerns, but that a thorough MSK assessment may also uncover things like muscle imbalances, so potentially strength issues or flexibility issues that can be addressed by a physiotherapist to improve function. And Mary mentioned earlier that it's important to ask about how a person living with obesity is managing day-to-day activities, and that includes mobility activities, so things like getting in and out of a shower or a tub, or maybe moving around in bed. Physiotherapists can assist with mobility assessment and treatment that may again improve function, and to assess ability to participate in things like physical activity or exercise. And that includes assessing fall risk or fear of falling, as Marie mentioned earlier as well. Often when somebody has a significant weight loss, there's an associated loss of muscle mass that needs to be addressed, as well as any issues that might arise from changes in a mobile panniculus or skin. In challenge category number 2, physiotherapists can help to manage and educate on associated conditions such as the ones that are listed here. Not all physiotherapists have special training in pelvic health or in lymphedema, so it's important to know if the physiotherapist you're referring to has that special training before referring to those specialty type areas. Similar to the occupational therapy tool, physiotherapists can also help with energy management. So we all have an amount of energy to expend in our day, and physiotherapists can help people living with obesity with expending energy really purposefully depending on their goals. And that includes spending energy on physical activity or exercise, and then balancing that with expending energy on activities of daily living, or perhaps using a mobility aid to conserve energy as well. Posture and positioning can have an impact on pain and mobility. And physiotherapists can assess posture and provide education and exercises, as well as manual therapy to address posture and positioning concerns. And activity counseling needs. So it's really important to understand a person's history and experience with physical activity before simply prescribing more of it. People living with obesity may have a complex relationship with physical activity or not, based on how they have experienced it in the past. So this includes assessing, as was mentioned before, for falls risk or fear of falling, but also looking at things like beliefs around activity or potentially pain with activity. Physiotherapists can assess the need for and educate on mobility aids and assistive equipment, such as the need for orthotic assessment or abdominal supports, and access to community resources. So Miriam had mentioned earlier in the presentation, the need to understand how people with obesity interact with places and spaces, and how this might impact their ability to participate in community programs or community places, for example, like a community swimming pool, or even other healthcare professionals' offices that you may be referring to. Physiotherapists can help to identify physical or mobility related barriers and work to address them with the person in a really collaborative way. We really hope that the inclusion of this chapter on enabling participation in activities of daily living for people living with obesity and the 3 practical tools will be helpful in taking a person-centered and functional approach to supporting people living with obesity in your practice. You can find the chapter on the Obesity Canada website at the address on your screen.
Thank you so much, Cindy, Pam, Mary. This has just been tremendous. I also want to introduce joining us for the panel today, Dr. Arya Sharma, who is professor and chair in obesity research and management at the University of Alberta, where he's also the medical co-director of the Alberta Health Services Provincial Obesity Program. And he did also spearhead the launch of the Canadian Obesity Network, which is now Obesity Canada. So delighted to have Arya joining us as well today on the panel. So just a reminder to all the participants, please pop your questions into the Q&A box for our panel, and I'll kick this off. I just would really be interested in the panel just sharing how they see that this space has evolved since the inception of Obesity Canada, and what it means to see this chapter actually appearing in these guidelines from your perspectives.
Thanks, Denise. It's Mary Forhan, and thanks everybody for joining. I'll start and then I'll open it up. I'll pass it over to Pam and Cindy to add. I think, so I've been an occupational therapist for 30 years, and probably at least 25 years ago, I started working with individuals living with obesity at a endocrinologist office that I was consulting for. And nobody else was really talking about these things. And it was really mind-boggling to me and to some of my colleagues who were also starting to have these conversations with clients that occupational therapy and physical therapy hadn't really been present in the area of helping individuals living with obesity in the area of participation. So since that time, or even earlier, even I would say 10 years ago, it was really challenging to be able to find equipment for some of our clients in terms of mobility equipment, such as a walker or a wheelchair. They were custom order items or special items and really, really expensive. And I would talk to manufacturers and say, you know, this is a market that's really important and underserved. And they didn't see the value in doing that. That it was,
a special item, it's not worth exploring. Well, now we've seen a real expansion into equipment that's available for individuals living with obesity, or just living with larger bodies. And I think the awareness of the contributions that occupational therapy and physical therapy can make to prevention, for helping patients everyday lives, or for patients who are in treatment for obesity. There's more of our colleagues that are saying, yeah, this makes sense that we're in this space. We have the training, we have the expertise, we just haven't applied it to this area before. So I'll stop there and pass it over. Maybe I'll pass it to Pam, and then Cindy can add some things too as well. Pam?
Sure, thanks, Mary. Yeah, I would definitely echo a lot of what Mary has said. I started working in this area just over 10 years ago. And from working with clients in both acute care and also in the bariatric specialty clinic, there's certainly a lot of different areas that people had questions about. And like Mary had mentioned in the presentation, a lot of people weren't necessarily asked about these things from their healthcare providers, and a lot of them were quite nervous or weren't even sure who to ask. So I'm finding that like people are a bit more open when healthcare providers do ask them about their daily activities, but also in terms of availability for different types of equipment. There's a lot more equipment options available in different sizes and weight capacities for people, which is helpful in the clinical environment as well. When I was working on the provincial bariatric resource team, we provided a lot of answers to clinical questions and got lots of questions about equipment, and we were able to provide some suggestions in terms of what kind of options there were. And now there's lots of different manufacturers that are making lots of different sizes of equipment, making it much more accessible to people. So I'll pass it over to Cindy, if that's okay.
Great. Thanks, Pam. Thanks, Mary. Yeah, I think you guys have covered it really well. I really see an evolution over the past 8 to 10 years that I've been involved in this work as well. And I think, one of the key points that the guideline makes is that obesity care should be based on evidence-based principles of chronic disease management, and that it must validate patients' lived experiences. And I think that's a really important key point, is validating lived experiences with mobility, with physical activity, with the way that they move, that people move around places and spaces, and then also really validating some of the ways that OTs and PTs can help people sort of navigate some of those day-to-day activities. I think we've really seen an evolution in that. There weren't and still aren't a lot of physiotherapists working specifically with people that live with obesity. And so now I'm starting to see groups pop up. Even in the UK recently, there was a group of physiotherapists that are now gathering to talk about their experiences and how we might best support folks living with obesity. So I think that's really exciting. And I'm really proud and excited that this chapter was included.
Great. And Arya, do you have a perspective you want to add to the question?
Well, I think, I met Mary about the first time probably about 15 years ago, or very close to when Obesity Canada started. And she was the one who actually made me very aware of some of these issues that we've just talked about and heard about. And I couldn't remember reading about any of these issues prior to that conversation that we had. And I think it's been very influential on the overall thinking behind the guidelines. I mean, if we take, for example, the Edmonton Obesity Staging System, where part of the staging system includes functional limitations, which sometimes can be very severe even in patients who don't have, metabolic effects of obesity, or, who don't suffer from some of the typical medical or mental health complications, but they might actually have mobility issues or other issues that, that can be as much of a burden in terms of just being healthy and being physically able to participate in things. So I think really this contact to this whole field of rehabilitation medicine certainly opened my eyes to it. And I think that the more that we've worked closely together, the more we've seen, and we've just seen it in this presentation, that there are numerous things that I think as physicians or healthcare providers working in this space we simply need to be aware of. and simply being aware of some of these issues can make a huge difference in the way that you approach patients, and sometimes also the advice that you give patients. For example, one of the things that I learned was, if patients can't see the stairs, then maybe using the stairs is not such a great idea. And which goes sort of, it's the opposite of what you would normally tell patients. To encourage patients to be physically active, use the stairs when possible, but please don't use the stairs if you can't see them. Similarly, the whole topic of energy conservation, which is something that physicians understand. When we talk about patients who have heart failure, for example, or patients who have chronic obstructive lung disease, I mean, these are simple things that we are aware of. But again, we just don't apply them to patients who have obesity. So one of the typical recommendations is, park your car away, away from the entrance of the grocery store. Well, what that actually means for the patient is by the time they've walked the 200 yards to the grocery store, they're already exhausted and need to sit down because they've just done all this physical activity moving around, and they might never make it to the produce section in the grocery store simply because they made the mistake of parking their car too far away from the entrance. So those are the kind of mistakes you make even in your counseling when you're not aware of the actual problems that these patients face. Don't ask a patient to collect a urine sample when you're not sure that they can actually do it physically because of their size. So thinking about some of these factors and working closely with Pam and Mary, certainly opened my eyes to a lot of these issues, which is why it was absolutely essential to include this chapter in the guidelines.
Mm-hmm. Thank you. Yeah, and so Lara has kicked off the Q&A section with just a question about the logistics of referral and how to connect people with these supports.
Yeah, thanks, Laura. I'll start because I'm going to pass this also over to Pam and Cindy because they're more closely linked with work in Alberta. My clinical experience is primarily in Ontario. So method of referral and how to access an OT or PT may vary from province to province. So typically, I never needed as an OT a physician referral. So sometimes I would get a referral from a physician. So if I worked, let's say at a hospital environment, we would get referrals from, let's say, a unit. So they might come from let's say an orthopedic unit or a neurological unit or wherever. And we would just get a general referral, typically usually to see a patient, to see and assess. They don't need to be really specific. As soon as you make a referral to an occupational therapist or a physical therapist, we will do our own assessments and make treatment recommendations that we feel are appropriate. In some cases, if an OT or a PT works for a specific program, they may need a referral from the referring physician. So that can certainly take place. Sometimes the patient can self-refer as well. So it's just picking up the phone and contacting a specific clinic, or you can find a list of private practitioners. Often they'll be through their professional organization. So the Canadian Association of Occupational Therapists will have a list of practitioners that in their area of expertise. And I believe that the Physiotherapy Canada also has, but I'll leave that to Cindy to expand on. So Cindy, maybe you can clarify referral processes for physical therapy, and then Pam, if I've left anything out, you can come in after Cindy.
Yeah, that's great. Thanks, Mary. So in Canada, physical therapists are also primary healthcare practitioners. And so any healthcare practitioner can refer to a physiotherapist. And in fact, patients can self-refer as well. Although sometimes in private practice, there's a physician referral that's required in order for some insurance companies to cover the assessment and treatment. So that's something to be aware of as well. And then as Mary mentioned, the Canadian Physiotherapy Association has a really nice Find a Physio feature, and so you can find a physio across Canada, and typically it even links the areas that the physiotherapist would specialize in. So that's a really great resource for that as well.
Mm-hmm. Pam, did you want to chime in?
Sure. I don't have too much to add. I would just add that just like physio, if people have extended health benefits, sometimes a physician referral might be required, but that's of course dependent on that benefits carrier. And Yeah, like some OTs are like in more specialized rehab programs. It might just depend on the program whether a physician referral is needed, but sometimes other, like usually other healthcare professionals can do the referrals as well. And with home care, that's even a self-referral. It doesn't necessarily have to be a healthcare provider that's referring. That's here in Alberta. So that could be different in other provinces, but that's pretty standard for here.
I would just add too, if you're not sure and you have any questions, just email Obesity Canada and we will make sure that you get directed in the right direction. So at least help you start that process.
Thanks, Mary.
And that was going to be my next follow-on question actually, was just wonder if you guys could reflect on the many years that you were working on the provincial bariatric team and the types of questions that you had for navigation and where you would recommend that, given that that doesn't exist now, where people could reach out to for information on some of those topics.
So I think Pam or Cindy, you were both on the bariatric provincial team, so I'll leave that one for you.
Yeah, it's a good question, and it's a resource that I think is certainly missed. We do also have the Diabetes, Obesity, and Nutrition Strategic Clinical Network in Alberta, which can be a resource as well. And then, of course, Obesity Canada is an awesome resource to reach out to as well. I don't know if you have anything else to add, Pam.
I don't think so, Cindy. I think you kind of covered all of it. That was what I was going to mention as well. Thank you.
Mm-hmm. Okay. And then I'm just wondering, Mary, could you expand a little bit on your Alberta initiative around the Safe Bariatric Hospital and kind of what that's about and help people understand some of the issues that come up in the inpatient environment?
Yeah, sure. Thanks, Denise. That's a great question. And so in Alberta, it's probably been about 6 years in the works now. So we got a grant from the provincial government to take a look at barriers to quality care. And it wasn't necessarily our intention to look at hospitals at that time, but what we did was we gathered together some healthcare professionals, primarily in the rehab sector, professionals who were able to who sort of were working maybe with clients with obesity and some who weren't. And we also wanted to speak with patients. So patients living with obesity who had experience accessing the healthcare system. And when we had focus groups and we started doing some surveys, we started hearing stories about the challenges, particularly in the hospital environment. And so we decided to focus in on that. So after our initial work, we started really working very closely with Alberta Health Services. And they've been wonderful. So this was with the Diabetes, Obesity, and Nutrition Strategic Clinical Network. And so we had a really comprehensive team from AHS and from my research group taking a look at key factors. So what we identified primarily was weight bias from healthcare professionals, and it was preventing patients from being able to ask for what they wanted and also feeling safe in the healthcare interaction with all touch points in the healthcare system, particularly in the hospital as a patient. We also were hearing a lot from healthcare professionals and from patients that there was restricted or limited access to equipment that was the appropriate size to support the patient's weight, and also if the equipment was available, that healthcare professionals didn't always know how to use it properly because it wasn't part of sort of their standard training. So another area that we really wanted to focus in was on safe patient handling. So with Alberta Health Services, we developed some training videos that are available online. And if you go to Obesity Canada, there's a link to a guide that was developed in conjunction with Alberta Health Services
that has been really focused in on making the healthcare or the in-hospital environment safer and more compassionate and effective for patients with obesity. So there's a really great link to a resource. We also started to look at training on how do we incorporate education, not just on weight bias and sensitivity, the safe patient handling, but how to be able to better understand what obesity is. And so by doing that, we're hoping to reduce some of the weight bias. Another key issue was being able to clearly recognize what the weight capacity of equipment is. And that sounds pretty basic, but when we started talking with healthcare professionals, we realized that a lot of times the weight capacity, let's say on a wheelchair or a visiting chair or a commode chair, a shower chair, something like that, was not readily available. We had to really look for it or look up the manufacturer's instructions. So developing a universal labeling system is something that Obesity Canada is unrolling now, so that it's a really quick and easy way to identify weight capacity to reduce injury. So I would encourage people to go to the Obesity Canada website. You can also go, I understand the in-hospital guide to provide appropriate care and safe, compassionate care for patients with bariatric care needs is also available through a link on the Diabetes, Obesity, and Nutrition Strategic Clinical Network's website. So I would encourage you to take a look there. Lots of great tips in there.
Yeah, it's really impressive work and so important, especially you know, transformative in terms of making sure people are safely handled, and so for staff and for patients. And Mary, I think you've had some really impressive results in terms of length of stay.
Yeah, well, we're starting to try to see that. So just in the data that we've started to take a look at is by actually making equipment available. So this actually came from a group in Ontario who replicated some of the recommendations that we talked about in Alberta. And what they started to find was that by making the equipment available and having the staff readily sort of knowledgeable about identifying bariatric care needs, it reduced delays in care, which actually contribute to increased length of stay. So the journey through the hospital or acute care system was reduced. And the predictions are that if we can reduce a length of stay by just 1 day, we can save the healthcare system millions of dollars. And that can be something as simple as not having the right lifting equipment available for a patient in the hospital that results in that patient spending more time in bed and not getting up and mobilized faster. Let's say after an injury or a surgical procedure, that could delay their length of their discharge date from hospital. And it's not because the patient isn't willing to get up and move about, it's because the environment is restricting participation in that healthcare service. And oftentimes we see patients with obesity being blamed for increased costs to the healthcare system. And what our project is really focusing in on is addressing barriers within the system to take that blame away from the patients.
Mm-hmm. Thanks, Mary. So just given that we're in these very unprecedented COVID times right now, and when you reflect on all the interactions that you've had with people living with obesity, what do you think the special considerations are that healthcare providers should be mindful of with patients during COVID? Is there anything special that you would recommend that people think about?
Yeah, that's a great question. I probably have a great answer for that if I had more time to think about it. But I think, one of the things, that concerns me is, with increased isolation, which I understand the value of, and I really respect the public health initiatives that need to happen to reduce the spread. I do worry that individuals living with obesity who might need some type of urgent care or support are not reaching out for that, or feeling even more isolated, to be able to have the supports that they may need in the home environment, or maybe being reluctant to seek emergency care if it's needed. So I think that worries me a little bit about the increased isolation that we are experiencing.
you know, as a society, but maybe being more reluctant to reach out for help. I think within the hospital environment, I'm going to pass this over to Pam and Cindy because they're more closely tied with that. But some of the concerns I think I would start off with there is the concerns about, you know, access to enough healthcare providers to be able to interact with patients, to get them up and moving and home as soon as possible if they happen to have an admission. So Pam, Cindy, I think this is more in your wheelhouse. I'm going to pass it over to you.
Sure, I can add a little bit to that. I think even just building on what Mary has said, even in terms of availability and space for equipment, and whether that's equipment used by patients inside the hospital or even being able to access equipment outside the hospital in terms of, and I'm not completely sure about what the situation is right now, but even just thinking about the loan programs that for equipment, what the availability of equipment is there, and even just from vendors as well. I think we know that supply for a lot of things has changed quite a bit in the last 9 months or so. So even just if people are getting discharged maybe quicker from the hospital and, you know, needing to be supported at home and be safe at home, I wonder if that might be impacting for people. Cindy, do you have anything else to add there?
Yeah, I think you guys covered that really nicely. And as Mary said, if we had more time to think about it, we probably could come up with something even more fulsome. The only thing I would add is just an impact in terms of physical activity. So we're getting into the winter months and streets and sidewalks can be a little bit slippery. And so whereas people living with obesity may have chosen to go indoors to a mall or to a different indoor space to get their physical activity, that will be quite limited now in terms of gathering in indoor spaces. And so there may be an impact in that way as well.
Mm-hmm. I think one thing just came to mind just to add to everything too is we're hearing more and more about the need for rehabilitation post-COVID. So, you know, the acute phase of COVID is one thing, but those who are recovering from it, those long-term effects that we're seeing, whether it be physical, neurological, mental health. So it's going to be really interesting to see how the rehabilitation services are able to meet the needs of patients living with obesity who may be post-COVID recovery.
Mm-hmm. No, that's a really interesting point. And so I think just the last thing I want to leave with is, you know, I think everybody who was contributing to these guidelines was so happy with the territory that was expanded, that was meaningful for patients. And this was obviously a hugely important chapter for that. And I'm just wondering, perhaps Aria, this is a question for you, you know, what have you seen internationally in terms of response to that, in terms of the change of the dialogue as it relates to just this expanded vision, you know?
Yeah, well, to be honest, I mean, these guidelines received an you know, unbelievable amount of international attention. So you know, just you know, based on media impressions, there've been over almost 100 million media impressions worldwide. And when the guidelines first came out, there was a lot of interest. I think every major network, you know, whether it was CNN or MSNBC or BBC or the Australian Broadcasting Corporation, they all covered the guidelines because there was just this, you know, this new sense that obesity was being redefined, and there was a whole different focus that was absolutely moving away from just weight loss and was focusing on health gain and really putting the patient front and center. So since the guidelines have come out, Obesity Canada has actually received numerous requests from a number of national, from other countries, their national obesity organizations, you know, asking for permission to adapt the guidelines or translate the guidelines or you know, modify them for their own needs. And currently, you know, Obesity Canada is working on creating a sort of a plan on how to do that. But it certainly speaks to the, you know, the importance of having these guidelines out there, not just for Canada, but in an international context.
Mm-hmm. Well, this has just been such an amazing session, and it's such an amazing chapter. So just congratulations to everyone who contributed to it. And thanks a million to all the attendees and those who are listening into the webinar of this, either live or post. We do really appreciate your feedback. So please take a minute to give some feedback. And also in the chat, the colleagues from Obesity Canada have highlighted about the OC Connect Pro. So this is an online community for health professionals to ask additional questions, and it's the obesity.timeright.ca. So please join, and that'll give you a great venue to carry on the conversation, especially if these are areas that you haven't necessarily thought of before and maybe are new to consider about how to integrate into your practice. Yeah, so with that, I think we'll wind it up for today. So thank you again to the panelists, to all the attendees, to the colleagues at Obesity Canada and the Office of Lifelong Learning for putting on the events. And we'll look forward to seeing you next time.